All right. So, yeah, I'm really going to be providing an overview of both binge eating disorder just as a diagnosis and just an introduction to our treatment approaches that the most common treatment approaches that we use with binge eating disorder. So, learning objectives today, hopefully by the end, you'll be able to describe the diagnostic criteria for binge eating disorder, including how to assess for those criteria, and then describe the treatment components of the different treatment approaches that we have for binge eating disorder and understand their effectiveness. And then also understand some of the future treatment directions and other considerations that we take into account with binge eating disorder treatment. So, starting first with the diagnostic criteria. So I'll start by saying the DSM-5 is actually the first DSM that has included binge eating disorder as its own diagnosis. So in the DSM-4 TR, it was considered to be a research diagnosis that needed further study. And so this is the first time we have official diagnostic criteria. So the first piece when we look at this is that the person must have recurrent episodes of binge eating. And binge eating is defined as eating in a discrete period of time an amount of food that is definitely larger than what most people would eat in a similar amount of time under similar circumstances. And then additionally, that the person experiences a sense of a lack of control over eating during that binge eating episode. And so we'll address both of those pieces in just a second in terms of how do you assess for that. And so in addition to the recurrent episodes of binge eating, the person must also experience 3 or more of the following during those episodes. So eating much more rapidly than normal, eating until they feel uncomfortably full, eating large amounts of food when they don't feel physically hungry, eating alone due to feelings of embarrassment about how much they're eating or what they're eating, and then feeling disgusted with oneself, feeling depressed, or feeling very guilty afterwards. The person must also experience marked distress regarding the binge eating episodes, and they must occur at least once per week for 3 months. And then finally, the binge eating episodes are not associated with compensatory behavior as we would see in bulimia. So that's going to mean they're not engaging in any kind of purging, vomiting, laxative use, diet pills, overexercising, anything that would compensate for the calories that they're taking in. And then it also does not occur during the course of either bulimia or anorexia nervosa. So a little bit more about assessing some of those, primarily criterion A. So how do you determine if the client is experiencing a loss of control during their binge eating episodes? So some questions you can ask would be, did you have a sense of loss of control at the time? Did you feel you could have stopped eating once you had started? Or did you feel you could have prevented the episode from starting? So these questions get at, do they feel almost like a compulsion to eat? And then also, do they experience, often what we'll see is that someone who's binge eating is doing so to avoid, and so they might not realize how much they're eating until the episode is actually over, and it's almost like they come to in a way. And so that second question, did you feel you could have stopped eating once you had started, gets at that a little bit as well. And then sometimes clients are able to just say like, yes, I felt out of control, or I do feel out of control when I eat a lot of the time. In terms of the other criterion, a aspect of the person must be eating an amount of food that is definitely larger than what others would eat in that scenario. You can start by just asking the client, typically, what have you eaten at these times? And get a sense for what is going on, what are they consuming, how much are they consuming? And then you can ask them, did you view the amount as excessive? So getting their idea of it. We do often kind of distinguish between a subjective binge and an objective binge. What the DSM is getting at is an objective binge, but we can start subjectively and get a sense for what is the client experiencing, and then we can determine as well what is going on. So after asking them, did you view this as excessive? You can also consider, like, okay, what would the usual amount be for a person under the same circumstances? So for example, this is going to vary. Let's say Thanksgiving is coming up. The person says, I had two full plates at dinner of both turkey and sides. That may not be that unusual given the circumstances of it's Thanksgiving. Probably a lot of the people at the table are doing the same. So in that sense, it may not be considered a definitely larger amount of food. Whereas if they were consuming that same thing on just a regular day, it could be. So taking into account those other aspects as well is important. One thing that we don't really take into account is what the person has eaten during the day outside of the episode. So if they're telling you they engaged in a binge at 10 p.m., we're not going to look back to breakfast or lunch and say, like, well, because they ate that then, the food that they had at 10 p.m. definitely constitutes like a total amount over the day that was more than normal. We're not taking that aspect into account here. And then the last piece, so the number of episodes. Generally, we take the client's definition of what a separate episode is as generally accepted. So if they are saying, I binged twice today, and they feel that they were separate binges, we're going to take that for their word, unless you were to assess more and determine there was an hour or more. So if they say, like, sometimes clients will come in and say they feel like they just eat for the entire day, like they just never stop eating. It feels like one whole binge throughout the day. That would be a time where we want to go back and look at, okay, was there at least an hour or more where you paused at some point and went and did something else? And then we could say that's probably going to be considered a separate binge. If yes, you binged and then you took 2 hours to go do some work and then you came back and binged again, we would consider that 2 separate episodes in general. So that's usually a hint that you want to do a little more assessment if they say, I feel like I'm just eating all day, getting a better sense for what does the schedule look like, how often are they pausing, for how long, that sort of thing. And then the last aspect of the DSM is the specifier. So we have 2 specifiers for binge eating in the DSM. So one is severity, and it ranges from mild to extreme. So mild starting with 1 to 3 episodes per week, and then ranging to the extreme end, which would be 14 or more episodes per week. And then we also consider remission status. So someone is considered to be in partial remission if their binge eating occurs less than once a week for a sustained period of time. And then in full remission if they have met no diagnostic criteria for a sustained period of time. We don't have a clear definition of what that sustained period of time is. That's left up to you. You might look at, okay, the criteria for binge eating is that this is occurring at least once a week for 3 months. So maybe we look at, okay, has it been absent for 3 months? You might take that as remission status. So I wanted to pause and see if there were any questions, if anyone has had issues with assessing or determining if someone meets criteria for binge eating in the past, or if anything else has come up there.
With the compensatory behavior part, I guess I'm wondering if a client has like had an episode or 2 or sort of once in a while, but it's not the norm. Is it essentially like if they've ever engaged in any sort of compensatory behaviors, we call it something else? Or is it, how do you sort of treat that part?
Yeah, I mean, I think that would definitely warrant just further assessment. So it's not that we're saying with binge eating that they can't ever engage in compensatory behavior. I guess, you would still look at, is there at least one binge a week where they're not, and that's occurring. But if they are having those, then you would want to look at both bulimia and anorexia as other possibilities as well, and determine, using those criteria and ruling those out, I would say first. And then if you can rule those out, looking at, okay, maybe this is just binge eating, or could it be, the other specified? Yeah. So I would say in general, I don't see much use of compensatory behaviors for those who I've diagnosed as binge eating, with the exception of like many of them, and we'll talk about this, are engaging in like calorie restriction, but that's not considered a compensatory behavior in the DSM. So.
That's a question. So I don't do a lot of treatment of binge eating, but I do supervise assessment of it, and I do assessment sometimes. And I find a lot of, that gray area of a large amount of food in a small amount of time, and my conceptualization is typically around like a 2,000 calories within that circumscribed. But I'm curious if you have thoughts on like types of food, because usually I see it being more like the typical junk foods, but I've also seen like whatever's lying around, and I'm just kind of curious to hear your thought process around like, I don't know, I don't know if it is less relevant in clinical practice if they're saying, this is a problematic behavior and I want to treat it, versus a research context where, sticking to the criteria really is more stringent. But I'm just curious about your thought process around like when it's kind of borderline, how to determine if it is a binge or not, and kind of how to think through that, because I run up against that a lot.
Mm-hmm. Right. Yeah, it's definitely, it's tough when you don't have those like set ways of determining that necessarily, and it is left up to you a little bit. I know, so I'll talk about Christopher Fairburn. He is kind of the mastermind behind CBT-E, which we'll talk about, and I would say is definitely highly regarded in the eating disorder field. His way of assessing, he has a great outline in his book, so it's called CBT and Eating Disorders. He talks about if there's any doubt on the clinician's part, that you would go with, okay, this isn't considered to be a large amount of food, like if you're unsure. Again, I think there is some room to err on the side of the client's experience as well. And if they're feeling like this is definitely more than like what I would typically eat, or what I think other people would be eating, I just take that as information. I don't necessarily take into account like what are the foods. As far as I know, there's no set, like it has to be like they're eating this kind of food, or it always has to be high fat, or whatever you might come up with. It can be just kind of any kind of food. So so there's definitely still some uncertainty.
Yeah, I've come across that as well, because I find usually it is higher calorie foods, but like I had someone being like, I just ate whatever was around, like cans of vegetables, which were like relatively low cal, but they were eating a lot of them, and it seemed consistent with a problematic pattern, as opposed to just, I don't know. I struggle with binge eating because it seems like there's a lot of gray area in the criteria, which it's maybe more of a research problem than a clinical treatment problem, but
right.
That's helpful.
Yeah. Okay. Good. And I could speak to again the newness of it, at least in terms of it being in the DSM, and honing some of that research criteria, or the criteria in future iterations of the diagnosis. And so I think that will come up too, in terms of just what you're noticing with what they're reporting, as we get into like, why do we think binges occur, and how do we use that information to treat them? So we're actually going to talk a little bit more about that in just a second. One other piece I wanted to highlight just from the DSM, this isn't necessarily a differential diagnosis per se, but acknowledging that obesity is often associated with binge eating disorder and recognizing that binge eating is distinct from obesity. So they're not one and the same. So those who, not all of those who binge eat are obese or even overweight necessarily. Yes, they're more likely to be, but not always. And then not all of those who are obese engage in binge eating. In fact, most obese individuals do not engage in recurrent binge eating. So we can't look at weight as a determinant for criteria with the disorder. However, so we found, or studies have found that those who binge eat are 3 to 6 times more likely to be obese than those without an eating disorder. And they're also more likely to have had an earlier onset of a higher weight or being overweight. And so actually about 30% of those with binge eating disorder report childhood obesity. So we do see those weight issues in this population. And in addition to that, we also see that those with binge eating disorder are more likely to have negative consequences. So they're more likely to have health issues than other obese individuals, and also worse outcomes for weight loss. So if they're attempting to lose weight, that's going to be much harder. They're also more likely to suffer from significant medical problems associated with obesity, such as diabetes or heart issues, blood pressure issues, those kinds of things. They're more likely to consume more calories in general. They're also more likely to have greater functional impairment and lower quality of life overall, have greater psychiatric comorbidity, and then just in general have more eating disorder symptomatology. So those with binge eating disorder are likely to have greater over-concern about their body shape and their weight. They're going to have a fear of weight gain. We will also often see dietary restriction in addition to binge eating. And then also, they're more likely to experience emotion dysregulation. So I wanted to focus on that for a second because we'll see that comes back into play with most of our treatment approaches here. So overweight binge eaters do report higher urges to binge in response to negative emotions, and compared to those who do not binge eat regardless of their weight. And the most common emotions that are reported to that they're eating in response to are things like anxiety, sadness, loneliness, tiredness, and anger. So those are kind of the top 5. And this brings into play escape theory. So you might also, or this is also known as affect regulation theory, but the idea, it was created in the early 90s. It states that individuals engage in binge eating episodes as a way to escape their negative emotionality. In particular, individuals engage in binge eating behaviors in order to escape their own self-awareness, often due to perceived failures on their part or feelings of inadequacy. Escape theory also states that those who are engaging in binge eating are using that as a way to focus on the present and external environment rather than their own internal negative states in those moments. So there's some avoidance there. And so, as I said, so that theory was first introduced in the early 90s. We've since had some research that supports this. So Whiteside and colleagues in 2007 found in their own study that difficulties in identifying and making sense of one's emotional states, along with limited access to emotion regulation strategies, was associated with binge eating above and beyond any other factors such as gender, food restriction, or evaluation of body shape or weight. So certainly we're seeing that emotions are playing a large role in binge eating. So with that, kind of going into some of the treatment approaches that have been studied in the research so far. I've kind of separated them into 2 different categories. The first wave being ones that we've been seeing again since about the early to mid 90s being studied. Those are behavioral weight loss treatment, CBT-E, or again, enhanced CBT, and then interpersonal psychotherapy or IPT. And then some of the newer approaches that we're still needing to see some longer term outcomes from include DBT and ACT potentially. I kind of put a question mark. There's not a ton of research out there, but the research that is out there shows it could be a viable treatment. So we'll first look at behavioral weight loss. So the main component of behavioral weight loss treatment is that you're targeting the excess weight. The goal essentially is weight loss. And so essentially those who are undergoing behavioral weight loss have basically a therapist guiding them through focusing on moderate calorie restriction, improving nutrition, and increasing their physical activity to lead to weight loss. So when I hear that, when I see that, I'm thinking this is a therapist-led diet, essentially. We do see some effectiveness with this. So in studies that have studied this, they see comparable effects to CBT in the short term for reducing binge eating. And then we also see a greater mean percent BMI loss for those who receive behavioral weight loss compared to other treatments, CBT and IPT in particular. However, both of these effects are generally short-term and go away at longer-term follow-up. And the research is lacking, from what I can see, in terms of any follow-up past 1 year, in terms of looking at behavioral weight loss specifically. But one of the studies that we do have showed that at 1 year, those who underwent behavioral weight loss showed more BMI gain than those who were in the CBT or IPT groups. And there were no longer significant differences in their weight loss. So initially, immediately at post-treatment, they showed a much greater weight loss than those who had undergone CBT or IPT, but they had gained that weight back at 1 year follow-up, and sometimes even gained extra weight in addition to where they started. So we see effects, but they're short term. And my conclusion with this is going back to we know that diets don't work. And in general, only about 5% of those who attempt weight loss in this way keep the weight off long term. And in that sense, we're talking about more than 2 years post the end of the diet, so to speak. There's lots of reasons for this. One that I often highlight with my clients who come to me wanting to lose weight is that's part of their treatment goal. I talk about deprivation, that our bodies are simply designed to seek out those things that we don't have. So it's kind of like the white bear example. If I told you not to think about a white bear, you probably weren't before I mentioned that, but now you're going to have a hard time not thinking about that. It's going to keep popping back into your mind. So same thing with food. If I said, okay, I can't have ice cream anymore, I'm going to want ice cream. I'm going to be thinking about having ice cream. I'm going to notice and be more aware when I'm walking past an ice cream shop, or when I walk past somebody who's eating ice cream, or when I walk by it at the store. It's going to be on my mind more. And that's just a natural response that our bodies have. So we're fighting that natural response when we diet. I wanted to also, so this book, which it's probably gonna be backwards, but it's called Beyond a Shadow of a Diet, I think is fabulous for outlining all of the research that has been done on dieting, highlighting some of the things that we found in terms of why diets aren't super effective. But I wanted to read an excerpt that kind of goes into more about this 5% of those dieters who are able to maintain long-term weight loss. The point being that, yes, they can maintain this, but it comes at a cost. It requires very restrictive guidelines that are stuck to. So they actually did an interview with a woman who is part of the National Weight Control Registry, which keeps track of individuals who have lost more than 30 pounds, and they check in yearly to see how they've been maintaining that weight loss. So they did an interview with one woman. So this book was published in 2014. So the interview was the woman finished her diet, so to speak, in 2006. So we'll say, she's been maintaining this behavior for at least 5 years, but probably longer. So since October 2006, she has weighed herself every morning and recorded the results in a weight diary. She even carries a scale with her when she travels. She also weighs everything in the kitchen. She knows the calories that are in lettuce or in flour. If she goes out to dinner, she conducts a web search first to look at the menu and calculate calories to help her decide what to order. She avoids anything with certain ingredients that she calls her gateway drugs. She has also found that drinking copious amounts of water seems to help. She carries a 20-ounce bottle and fills it 5 times a day. She writes down everything else she eats, and she exercises from 100 to 120 minutes a day, 6 to 7 days a week. So going back to some of the things that those with binge eating disorder are more likely to experience, including a lower quality of life. To me, personally, it's just an opinion, I guess, but that does not sound like a high quality of life to me. And they actually go on to say that a lot of experts would look at that and say, those are the same symptoms that I'm seeing in other eating disorder clients. So is this woman really just maintaining her weight, or is she engaging in eating disorder behaviors? So just thought that was an interesting excerpt in terms of, sometimes clients can get focused on that. Well, maybe I'm one of the 5%, but okay, yes, but then what do you have to do to maintain that? So taking that into account that, okay, yes, we have this behavioral weight loss treatment. It's effective in the short term, not in the long term. What can we do to address other aspects of binge eating that we're seeing? That leads us into enhanced CBT or CBT-E. So as I mentioned, this was developed by Christopher Fairburn, and it's based on the restraint theory. So that the restraint theory says that at the core of an eating disorder psychopathology are dysfunctional thoughts related to the body and self-evaluation. And then any other eating disorder behaviors that occur are a result of these dysfunctional evaluations, with the exception of binge eating. So he adds in that for binge eating, it results from dietary restraint aimed at lowering body weight and increasing body satisfaction. And so essentially there's a cycle of food restriction that leads to a cyclical pattern of restriction and binge eating. So Fairburn does say that food restriction often will come first. Other research has kind of shown it's almost like a chicken or the egg at this point. We don't know whether individuals begin binge eating and then that leads them to food restriction at some point, or if they begin with food restriction and that takes them into binge eating due to deprivation. But there is that cycle that eventually happens. And then in addition to this, he says, binge eating isn't occurring at random. Even if our clients are saying, I'm not sure why this is happening, it feels like I just did it. He says it's almost always triggered by either a negative mood and or an adverse daily life event or events. So given that theory, CBT-E aims to break the cycle by addressing thoughts and behaviors that trigger the binge eating. It is a manualized treatment. It's a 4-stage treatment that is conducted over 20 weeks total for 20 sessions. But it's also individualized. So basically when you're doing CBT-E, you construct a formulation through asking the client several questions to identify the processes that are maintaining their pattern of eating disorder psychopathology, and then using that to identify the features that need to be targeted. So you might have one client who is just very actively engaging in food restriction, and then that leads to their binges. So first and foremost with them, we're going to be targeting the food restriction aspect and trying to implement a more regular eating schedule. Whereas another client might say, it's the adverse daily life events. My job is so stressful that every night I come home and I binge as a way to cope. So then we might look more at those thoughts and behaviors surrounding the job that then lead to the binge eating. So it's slightly individualized and can be revised as the treatment proceeds and the client makes progress. There is a initial emphasis for everyone on regular eating, and I'll detail that a little bit more in a second. But part of that is Fairburn believes kind of a buy-in. So when someone who's binge eating starts eating on a schedule and more regularly, they notice pretty quickly a decline in the binge eating. So that gets them excited, they see change, and then they buy into the treatment, they're more likely to stay in treatment and continue on. So that's part of the emphasis there. In addition to just, there's some other benefits that we'll talk about. Before I go into regular eating, just to highlight the studies that have shown or been done to determine effectiveness of CBT. There have been a few. So most studies indicate around a 50% remission rate, or another way of saying that is someone who's remained abstinent from binge eating at follow-up. So again, not super high. We've got some effectiveness. Just a little more detail about that. So there a couple of one-year follow-up studies done in 2010 and 2012 showed CBT at about 51% remission rate, or there was another one that showed a 61%. So there's a little bit of variation there. And then we have one study that did a 4-year follow-up, which is the longest follow-up that I'm aware of, and determined about a 52% remission rate, or 52% of participants were remaining abstinent from binge eating at that time. So that's about where we are with effectiveness with CBT. Again, just highlighting regular eating, because I think that this is a component, even if I'm not choosing to do like manualize CBT-E with a client, I'm bringing in regular eating. I do think it's a very important component of this treatment. So basically what it is real-time self-monitoring. So the client is recording their food intake daily for each meal, and ideally as soon after the meal as they can, because they're not just recording their food, they're also keeping track of their thoughts and their feelings and any other experiences that they have that occur during their meals. So this is viewed as a foundation upon which other changes can occur, mainly because it helps the client identify exactly what's happening. So on the chart that they keep, they can mark whether or not the meal ended up in a binge. So they've got some awareness around that. And then also just that self-monitoring helps them to change. So they can start to learn that they have a choice, that certain things, you know, if they notice a pattern, like, oh, when I eat ice cream, I have this thought, I could potentially change that thought, and that might enable me to feel better about eating ice cream, and I can do that. Or every time I eat ice cream, I notice that it ends up in a binge, and I have this thought. Basically, they're able to just create more awareness and then put in effort and practice into changing those patterns. One thing often what I will encounter when I ask clients to do this is that, not all, but some of them will say, like, I can't do that. Like, I would become so obsessed if I kept track of everything that I was eating. One thing I forgot to mention, we're not keeping track of calories as we're monitoring this. So that's something that is not included. Weight loss in general is just not a focus of really any of the other treatments that we'll talk about besides behavioral weight loss. So, and that's true. Like, it does increase preoccupation with eating, but only for about a week or so is what has been found. So it's essentially almost like an exposure in a way where they're going to experience some increased preoccupation or anxiety, but that's going to go down with time. And then also just to kind of highlight, so what they're actually recording is the time, and then they can label the meal as well. Then they track the food and drink that's consumed, where they were when they ate, and then they can put an asterisk next to it if it was a binge, and then any context or comments. So that's where they're going to include any thoughts or behaviors, feelings that were occurring during that time. during that meal time. One other aspect of regular eating is that it is pretty structured in that you're asking the client to eat pretty much always 3 meals and then either 2 or 3 snacks throughout the day. And it's structured such that if they're eating 3 snacks, it's going to be breakfast, mid-morning snack, lunch, afternoon snack, dinner, and then after dinner snack. For binge eating, typically we're going to see 3 meals and 2 snacks. 3 snacks is generally more for those who need to weight restore. And so then we would just take out the mid-morning snack, unless, again, you can leave this up to the client. If the client is saying, I usually have to get up really early and then I don't get lunch until a little bit later, they might choose a mid-morning snack rather than a post-dinner snack. It's kind of based on their schedule a little bit. But yeah, so you're also having that structure as well. And the clients can build up to this. So they don't have to start with, if they're not used to eating 3 meals and 2 snacks every day, they don't have to start with like full snacks or really full meals. They can build up to that. But again, we're going to see even just kind of a natural spreading out of those meals as their binge eating continues to reduce. So that's a really important component, again, of CBT, but then I think useful in general for treating binge eating, regardless of which treatment you're using. Next, going into IPT, or interpersonal psychotherapy. So this was formulated by Whiffley for binge eating treatment, and is believed to be effective because it targets the negative affect that we've outlined in the escape theory. So mainly working more with clients on their affect and the interpersonal issues that come up that lead to negative affect. IPT for binge eating generally doesn't talk a whole lot about the eating behaviors itself, in terms of you're not looking at like, what are you eating throughout the day and that sort of thing. Basically, you're first determining the interpersonal context within which the eating disorder developed and is then still occurring, and identifying which problem areas need to be targeted for the individual. So again, it can be individualized while also being a manualized 19 to 20 week treatment. It does also show effectiveness in studies that have been done for IPT. We do see that they have a slightly greater abstinence of binge eating at long-term follow-up than CBT, or certainly than with behavioral weight loss. So going back to that 4-year follow-up study, again, they found a 52% abstinence rate from binge eating for CBT, but those who engaged in IPT actually showed a 76.7% abstinence rate. So that's actually a pretty great outcome for that study. Generally, if we're looking more at 1 to 2 years, the remission rates are about the same as compared to CBT. So within that like 50 to 55% abstinence rate. And that's interesting that it seems IPT tends to build over time. Like as time goes on, we see more of an abstinence from binge eating. And I'm not sure that we really know what that mechanism is at the time, but yeah, just an interesting anecdote there. And then lastly, so kind of moving into the newer wave treatments, the last therapy that I really want to highlight is dialectical behavior therapy, or DBT. So SAFER, I believe in the early 2000s, developed a program for DBT for binge eating disorder. So this is another 20-session treatment, seems to be the consensus there. That was primarily an adaptive emotion regulation skills training. So the most DBT skills that are taught are emotion regulation. There's also some mindfulness and distress tolerance included in there. Interestingly, given that we've seen some effectiveness with IPT, there isn't really a focus on the interpersonal effectiveness skills in this manualized treatment. But what they've found in terms of kind of immediately post-treatment, as they were building this group treatment, they found significantly improved weight and shape concerns and eating concerns, as well as abstinence from binge eating. But we don't have any really long-term outcome studies to support this post-treatment. We do have one study, Robinson and Safer conducted in 2012, that show that DBT was effective for treating binge eating disorder compared to a comparison group. So they have done some studies comparing to other treatments. But this was moderated by those with avoidant personality traits found DBT more effective. And then also those who had an earlier onset of binge eating, so prior to age 15, also had a greater effectiveness with DBT. And again, we go back to escape theory here in terms of, we believe that with DBT, you're teaching clients how to manage their negative affect in different ways besides the binge eating. And so that is going to help with this trying to escape negative emotions, basically. I kind of added this part on myself, but I think the mindfulness skills could also be a factor there, especially as we go into some of the other considerations, but just sort of in the same way that regular eating enhances awareness of the self, the mindfulness skills are certainly going to increase that self-awareness and noticing any patterns that might come up as well. So in summary, with the treatments that we have explored in research studies so far, it seems like some of the most effective components of treatment are the regular eating, or having some form of more structured eating for the individual, and then having alternative emotion regulation skills that are introduced to teach them other ways besides binge eating to manage their emotions, and then also addressing the underlying negative affect that's occurring, and looking at possible reasons for that, trying to help the client solve those issues. Overall, though, I encountered another study that was looking more at the effectiveness of CBT, Leonardin in 2018, and basically their conclusion was continued efforts toward improved eating disorder treatments are necessary. And I think that pretty succinctly sums up where we're at with this. Like, yes, we have different components that are effective and that we think are working for different reasons, but there doesn't seem to be a treatment that combines all of those into one. So we're kind of often left with certain aspects maybe not being met at the end of treatment. So I've certainly experienced this myself with clients who, we always start with the more like, let's establish regular eating, let's identify patterns that might contribute to your binges. And I've had clients who are really successful at that, and they get to a point in a few months where they're eating regularly, they're not binge eating anymore. But for whatever reason, they're still not quite ready to address the underlying negative affect or the things that are contributing to that. So I've had people leave, once they have reduced the binge eating, which really was their goal in coming to treatment, they leave. And so that might also contribute to not seeing necessarily like long-term effectiveness. Those clients are probably going to come back at some point because the underlying issues haven't been addressed. So we're still in need of finding a treatment that incorporates all of that for the client. Briefly, some other considerations. So I mentioned mindfulness, or also mindful eating. So just, again, enhancing awareness around like, how does it feel when you're eating? What emotions are you experiencing before, during, and after a meal? How does the food feel within your body? Those sorts of things can be really important components for clients to become aware of. Intuitive eating is another aspect that has been introduced more recently. Some consider mindful eating and intuitive eating to be the same thing. But mainly the first goal with intuitive eating is to distinguish between, is the person overeating in response to their emotions, or, are they overeating or binge eating because of a lack of self-care? So, did you forget to eat lunch today and now you're overeating because it's dinner time and you are hungry and you skipped a meal today? Or is it because of negative affect or something else going on? I find intuitive eating to be very helpful for clients. One thing I will say is it's not going to be a starting point. Going back to deprivation and just frequent calorie restriction that we're going to see with binge eating, in addition to then also overeating, ignoring the fullness response that our body is giving us. Intuitive eating relies a lot on eating when you're hungry, stopping when you're full. So often clients, especially when they first start seeing me for binge eating, aren't getting one or both of those hunger or fullness cues. And so we really have to work. That's another thing that regular eating helps the client to build. You know, their body starts to see, okay, I can expect food at these times, you know, I can rely on you to provide me with this. And so then it starts to bring back those signals. Starting with intuitive eating would be very difficult, especially for those clients. So it's something that I tend to introduce more as they have stabilized, have reduced binge eating, starting to focus more on, okay, how does your body feel when you eat? You know, are you looking for emotional comfort when you're craving this food? And examining the pros and cons of that. We don't say like you can't ever seek out food just for comfort. Sure, you can. Like you don't always 100% of the time have to be hungry before you can eat. But just looking at the pros and cons, looking at could there be something else you could try first that might actually be more effective in giving you the comfort that you need. Or sometimes maybe you just really want ice cream because you're sad, and that's fine too. Kind of more of the intuitive eating approach. Another thing that's coming out or that we're hearing more about is health at every size. So this is made up of 3 different components. So the first is respecting like body diversity, celebrating everybody as it is, regardless of weight and other aspects. And then also critical awareness of how society impacts our choices in terms of what we eat or how we eat. It essentially is a complete rejection of diet culture, but just also recognizing, you know, am I making this food choice because of me or because I think someone else is going to judge me for this? And then finally, having compassionate self-care. So that's going to go back to some of those intuitive eating principles, choosing foods that are going to feel good for your body, and also choosing movement or exercise that's going to feel good for your body. That's another thing that I do incorporate when I talk to clients and asking about exercise. I really emphasize more of just how are you moving your body and how does that feel for you versus are you going to the gym and working out, you know, doing cardio 30 to 60 minutes a day. So those are some of the aspects of health at every size. And then finally, I mentioned this before, but ACT or acceptance and commitment therapy. We do have some studies that are showing at least immediately post-treatment that this can be effective, probably because it is targeting experiential avoidance and increasing acceptance and awareness for the clients. But we simply don't have the long-term studies or long-term outcomes to really know or have a good idea of the effectiveness of ACT for binge eating at this time. So that's my kind of overview of treatment. So I'll leave it, we've got about 10 minutes for questions.
I'm curious, Brittani, if this treatment, there's benefits to collaborating with primary care physicians and what your experience has been there, partially because I'm aware that while it's really good to see the health at every size movement and increased awareness of body diversity and lack of reliance on BMI, my understanding is that some medical professionals are still utilizing BMI in ways that aren't really serving patients. And I'm just wondering what you're finding with that.
Yeah, I mean, I think there's definitely an argument for maintaining contact with the PCP. Certainly, it can be complicated though, depending on how much they're focusing on. Just like if they're very hyper focused on the client needs to lose weight. I think it's similar. So looking at if I were treating someone with anorexia, for example, you know, we want to be involved with the PCP and evaluate for any kind of medical concerns up front. So I think the same is true for binge eating. We want to know, is the client struggling with some of these, high blood pressure or other issues that go beyond just their BMI is more than we want it to be. And then again, just so I mentioned that these treatments don't focus on weight loss, but typically we're going to see some weight loss. Just in addition, naturally, as the person stops binge eating and reduces the binges, there's going to be weight loss, where they're going to kind of normalize more to sort of their set weight or where their body is content with their weight. And so then looking at, okay, even if the weight isn't going down necessarily, are we seeing decreases in those other health issues that were of concern? So I think it's certainly helpful to have some monitoring happening.
Brittani, I had a question about this sort of component of regular eating. I'm always fascinated by, that seems to be a core component of most eating disorder treatments, and it comes on board really quickly, right? It's like the first thing you're talking about is like, okay, basically stop doing the thing that you have been doing and now start this entirely new behavioral pattern. And I guess I was just curious, and maybe this has to do a little bit with like kind of who's best suited for certain treatments, but especially if the kind of mechanism of action that's often proposed in binge eating is, okay, this is a failure of emotion regulation. And then you're kind of saying like, well, stop the thing you do to regulate your emotions, but you haven't necessarily come up with alternatives yet, or maybe you are at the same time. I guess I'm curious about like kind of timing and if you notice any differences in the clients who maybe sort of struggle to regulate their eating so early in the treatment, or just kind of how you think about that.
Yeah, that's a good question. I almost see it as an opportunity, bring in a little DBT, but to do almost like a chain analysis. Maybe the first couple of weeks, it really is an observational thing to see, okay, what comes up when you're told to stop this. What do you notice? Do we see an increase in binging, or are you noticing like, okay, I don't know how, maybe the thing that they're struggling to cope with comes to mind more of like, oh, this is what's really the trigger for me, because now I'm saying I don't know what else to do with it. So using those first couple of weeks to really highlight that and identify that pattern, and then we can start looking at, okay, what do we do in response to that? So it certainly isn't, it's a component of treatment, but it's not the only thing we're talking about after like the first or second week. It certainly takes up more time as you're introducing it and giving all of the different aspects of it to the client. But after week 2 or 3, you're able to have that space to talk about, okay, what do you do in response to these thoughts or the patterns that you're seeing, the behaviors, and teaching alternative skills. And another interesting thing that I've seen in a current case that I have going on, again, is that, sometimes that thought is even just, I can't do this. So part of regular eating for binge eating is that you're going to start to introduce what we call like fear foods, or foods that the client says, I'm not allowed to have these foods. So again, we're trying to reduce that deprivation. And so sometimes clients will be very resistant or just like, no, I absolutely can't. And so even just as they're going through and recording, in this current case, I had them notice, like, I guess we're about 4 weeks in, that they had a food that has always been on their no, I can't have this list. And not only did they have it, but they also did not binge when they ate it. So some of it also just comes about organically over time. And with that, I just kind of keep sticking to, I validate like, yes, this is hard, and, hopefully we'll get there. And then they're able to eventually get to that point on their own. So.
You might have answered my question there, but I don't work a lot with disordered eating. I find it to be a very difficult population that I don't really have the skill set for. I appreciate that when it comes to the monitoring stage, you're not asking for calories, you're not asking them to weigh in. How do you talk about honesty in therapy? Because if I was a client of yours and I was trying to lose weight, I wouldn't be honest.
Sure. Yeah. Yeah, I think there's definitely an element of shame that comes up as clients are monitoring. And so I really emphasize the non-judgmental aspect of treatment, that I'm not asking you to write these things down in order to judge you for what you're eating. It's really just for us to know, and even just for them to know, okay, here's what happened. I had this food, and if there was a binge or there was a negative thought, that they can go back and look at, could it have, if that happens multiple times, is this food there each time, that sort of thing. So just highlighting, it's really just informational. And I think often it does help to just remind them, like, we're not looking at, I'm not even having them write down amounts in terms of like, I had half a sandwich or something like that. It's really just about, this food was present in the meal and here's what happened as a result. So I think that generally is helpful for them. Once I review that, I don't have too many who are super resistant to recording.
Oh, that's good to hear. I didn't know that it didn't include volume. I think when you get rid of that, it helps to get rid of a lot of the shame.
Yeah. And I kind of leave it up to them, if they're comfortable with volume, they can certainly include it, but that's definitely one piece that I think can help, is you don't even have to say how much you have. So, yeah.
Thank you. Great presentation.
Thank you.
Yeah, Brittani, fantastic. Thank you so much. This was really great. And just a good reminder that we do have a number of handouts, including food log sheets in our intra-office website that you can access. And I'm happy to kind of send a link to those as well, but lots of resources for you to utilize with clients if you wanted to send them that. So thank you. Good to see you.
Thank you.
Thanks, Brittani.